We are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hello, welcome to the podcast series for the Association for Child and Adolescent Mental Health, or ACAM for short. I'm Umar Toseeb, Professor of Psychology. My research focuses on special educational needs and mental health in childhood and adolescence. Today I'll be speaking to Dr. Bettina Moltrecht and Dr. Mauricio Hoffmann, co-authors of the paper Social Connection and its Prospective Association with Adolescent Internalizing and Externalizing Symptoms, an exploratory cross-country study using retrospective harmonization, which has been published in the JCPP. The paper will be the focus of today's podcast. Bettina, Mauricio, thank you so much for joining me.
Thank you for having us. Hello.
Thank you.
Shall we start with a round of introduction? Tell us what you do and your research and professional backgrounds.
So I'm Bettina Moltrecht. I'm a senior research fellow at UCL, so the University College London. I'm based at the Centre for Longitudinal Studies. And there I'm sort of doing population mental health research. And when I'm not there, then I'm based at the Anna Freud Centre, where I'm doing sort of more child and adolescent mental health research around sort of digital interventions, sort of more clinical applied work.
So my name is Mauricio Hoffmann. I'm a professor of psychiatry in Federal University of Santa Maria, South Brazil. I'm a clinical psychiatrist as well, active. My research is around child and adolescent mental health with longitudinal studies. I used to work more with educational outcomes. Now we are more applied to measurement and try to test different measures that to better detect and predict mental health problems.
Thank you both. The paper is about social connection and adolescent mental health symptoms or mental health difficulties. And one of the things that I liked about it was your conceptualization of social connection, as in you didn't just look at individual factors, you put them under this broad umbrella of social connection. So do you just want to tell us about your definition of social connection? What does it mean in the context of this paper?
Yeah, that's a very good question. We kind of used the work by Hold Lundstedt, I hope I pronounced that correctly, because basically there are many discussions around what social connection is. I think in my head, it's a fundamental human need. We all need to be socially connected. There's a big sort of challenge in society today where people are experiencing sort of loneliness, they're disconnected, but we know that it's sort of important for our mental health and sort of across the lifespan. And then while we were trying to kind of get into the data that we had available and our research questions, we were trying to understand what does social connection mean when we have to measure it. And it's really kind of consists of multiple facts. So it's not just one thing that you can measure. And then we found that paper by Holt Lundstedt, and they have basically sort of defined it as under three different dimensions: the structural, the functional, and the quality. And we thought that fit quite nicely with our research question and the data we have available. At least sort of if we talk about the structural dimension, you have things like the size of the social network. So how many friends does someone have? Or in our case, we had something we call household composition. So that could be who's living in your household. Is it siblings, your parents, or maybe even like a grandparent? And then the next level is the functional. So that's just sort of, do you get social support from your relationships? Maybe if you're a parent and your neighbors support you with childcare, then there's also a function to that relationship. And then the last dimension is the quality. It's not just about how many friends we have, but that the quality of our relationships is important. You know, you could have 10 different friends, but if you don't have a good relationship with them, or it's sort of with high conflict, then that, it's a different relationship, or has a different impact on your mental health than two friends that you can rely on and you have a sort of a trusting relationship with. So these are the three kind of dimensions there.
Thank you. And then in terms of mental health, that you talk about internalizing and externalizing symptoms. In the context of this paper, what did those look like? What did you specifically measure in terms of internalizing and externalizing symptoms?
So first, the concept, right? Internalizing symptoms, there's a broad concept that put together depressive, anxiety symptoms, usually, right? So internalizing is the process of you don't expose much in the externalizing world. So you feel all in your mind. So that's the idea made by Achenbach in 66. And then externalizing symptoms would be more the behavioral side of things. Like in this context, we use the SDQ instrument. So if you cheat, lies, and you do this kind of things that you can observe, right? And the internalizing symptoms is more like fear, crying a lot, this kind of things. So you use 5 symptoms each. So you use this instrument to take these aspects of psychopathology, basically.
Thank you. And I was having a conversation with a colleague recently around externalizing psychopathology, and I'd written something where we talked about hyperactivity and inattention being forms of externalizing psychopathology, and the colleague said inattention isn't really externalizing psychopathology, and I don't know what to make of that, and I just wondered what your thoughts were.
You are going in the rabbit hole. This is in terms of like a lot of people working in the structural aspects of psychopathology, like the high top consortium, etc. So some people don't know how to place the inattentive side of things. Like, example, the high top measurement, the high top structure, for example, don't have a proper place for that. But in terms of factor analysis, you can factor in, like, it tends to converge. The 8 symptoms, like inattentiveness, lack of concentration, this kind of things, tends to convert to externalizing symptoms, but are not really the same thing. So what we use, like myself included, but some people, that is actually a separated construct, really. Sometimes it's in the between, like concentration. Like, for example, if you take the symptom of concentration in itself, lack of concentration is a symptom of generalized anxiety disorder, is a symptom of depression, and the symptom of ADHD. And it's not a symptom of conduct disorder, oppositional defiant disorder, this kind of things. So it's in more or less in the between. But in terms of factor analysis, you can put it together. We didn't put that together. We did actually separated the ADHD part of the SDQ. So we only included the proper behavioral, this concept of behavioral symptoms, not the hyperactivity ones, not these kind of things. So you can find arguments for putting together with externalizing or not. In terms of the conceptualization, I think it's really don't belong to the externalizing aspects of behavior.
Thank you. And you've done this study on 2 different cultural contexts. So you focused on the UK and Brazil. Why these 2 specifically, and why is it important to look at 2 very different cultural contexts with reference to the specific questions that you're interested in?
So I think there are multiple reasons. So when we started out with the project, we developed this tool called Harmony. The idea behind it was that to really encourage more global mental health research, because especially if we look at young people, we know that 90% of all children and young people live in low and middle income countries, but actually most of our research is conducted in high income countries. And if you sort of take that a step further, thinking about interventions, we can't really expect that, like taking an intervention that was developed, let's say in the UK, that it would work the same way when you place it in Brazil. So that's why we kind of said we need to kind of have more of that research that tries to compare different studies, or countries, not just studies, but countries, so that we have a better understanding of what works in which countries, where are the differences, where are the similarities, and why Brazil and UK. Well, one is part of the high income countries and the other one is a low and middle income country. But then there were also the practical sort of reasons, because we knew each other, and I was sort of more familiar with the Millennium Cohort study. I had not heard of the Brazil cohort study before, and then Mauricio, well, you had worked with both, I think, before, and that we thought was a good sort of way, bring the 2 studies together. And I guess another practical reason was that we could align them in some way, so the data, they're roughly similar in terms of the age of the participants when they were born. I mean, there's slight differences in the study designs, but it seemed possible that we could combine the data sets as well.
Yeah, so there is the two types of questions, right, Bettina? The more elegant one, which is comparing low and middle income countries with high income countries, etc. But there is a more or less boring one, which is is the practical ones. We get together in this grant, and the grant demands to do these kind of things, to have people from different places besides the UK. And Brazil suits the bill quite nicely, especially because it's the largest country in South America, is a low and middle income country, and the cohort fits. It's possible to harmonize with the Millennium Cohort. This is a key thing of harmonization, right? We had some variable, especially because data was collected more or less at the same time. So we don't have different cohorts really in terms of year of birth. Like the Brazilian cohort is an accelerated cohort. We have different ages, different birth, but the mean is the same as the mean age, the mean year of being everybody was born, almost match the same year as the Millennium cohort. So this fits the bill quite nicely. It's possible then to harmonize, and it's not every chance we have to do these kind of things.
just to add, we also explored this with not all of them, but with a researcher based in South Africa. And there we just had to kind of realize that there wasn't enough overlap in the data set. So we just couldn't do it because they didn't have enough mental health sort of measures in there that we could have done the same thing. So this was just a very good opportunity for us in terms of the data that was available to answer like this sort of new research question. Yeah.
And you've already touched on this already, so let's expand on this. Data harmonization, what is that? What does that mean? And what did you do in this study?
I probably should say we're talking about measurement harmonization in the first instance, because sometimes data harmonization is quite a broad concept, and sometimes people confuse it, but we are basically talking about retrospective measurement harmonization. So that means that in this case, we're looking at the two data sets and what measures they have used and whether they're even comparable. So we often sort of use this example that if you want to measure depression, there are more than 200 measures that researchers, clinicians could use to measure depression. So different studies might use a different measurement. So just because, one study uses measurement A and the other one uses measurement B that both claim to measure depression doesn't mean we can just put them together and compare them. So that's why we do the retrospective sort of harmonization. In real life, this kind of looks like sort of and this is what we did as well, Mauricio and I. We went through the sort of metadata, all the sort of study item descriptions in both studies to identify what is common in the first round. We wanted to know what's actually measured in both, just on a broader concept scale. Does Brazil ask about friends? Does the Millennium Cohort study ask about friends? What does Brazil say about household? What does sort of the Millennium Cohort study say about household members? So then we went through the PDF files really and Excel sheets to figure out what they both have in common. And then you go onto like an item level where you go really sort of item by item trying to compare, do they actually say the same thing? So, it could be that one study says, I have trouble relaxing, and the other study says, I'm unable to relax or something. So these are similar, but they're not necessarily the same item. So that's where the harmonization comes into play, where we try to kind of take an item by item approach to say how similar are they actually. And then once you've identified the items that you think are semantically similar, then you go to sort of the next stage, and that's where we've described it in the paper as well. So you have sort of you measure your invariance. Are they actually sort of measuring the same thing in both studies? That's not the semantic level anymore. So I hope I have lost anyone by that description. But
so just to clarify there, once you've got past the semantic bit where you've on an item level, is there are these two items asking about approximately the same thing? And you've gone on to the next level. Is that the measurement invariance bit? And is that the same as a measurement invariance testing, or is that something else? Because I think what I was wondering was, when you were going through the review process, I imagine a hardcore quantitative reviewer being, what is this? Like, this is where's the numbers here? Where the model fit statistics here? All of those things. So what's the process there? So I think I understand the qualitative bit of two people or two researchers agreeing or disagreeing on the semantics of what's being asked. And then the quantitative bit, what does that involve?
Just a step back, I told some friends that we did a harmonization paper and they said, what? You are harmonizing not facial harmonization, which is something that people do in Brazil in the lips and stuff, but you're doing for data, you are making up data? That's not it, right? So data harmonization is this process, as Umar and Bettina was saying, like we have different instruments, for example, GAD-7 to measure anxiety and scared. So with Thomas developed this tool in our group, do that automatically. So we put the questionnaires, the metadata there, and then it matches the items that are more similar based on semantics using natural language processing. That's the thing, right? So this is the process of harmonizing instruments at the item level. The other thing is the quantitative part, which is to test if this final measurement are equivalent. So this is the measurement invariance part. For this study, we already have the same instruments in both cohorts, which was the SDQ. So we didn't need to make harmonization for SDQ. We just tested if the SDQ is understood the same way in Brazil and the UK, basically. So differences in the levels of the SDQ were solely due by the differences in the symptom level, not because people in Brazil are understanding differently the items or something like that. Then we did a measurement invariance testing. All that are in the supplementary material in the paper. After we did that, we used the scalar invariant scores to the analysis, right? So what is that? That means that the relationship with the item, with the construct, which is internalizing symptoms, are the same in both countries, and the levels of difficulty of the item. So, for example, for me to answer that item that I cry a lot, that's totally true. This is a very difficult item in terms of psychometric speaking. So what is difficult item is I need a lot of symptoms to endorse or to respond the item that way. So that's totally true. This is a threshold parameter, which is set to be the same in both countries. So this is all technical stuff, but to mean that the scores that we have, we ensure that the differences between countries are just because of differences on symptoms, not other interferences of other things, right? Cultural aspects, blah, blah, blah. That's the quantitative part in the measurement invariance. I don't know if I answered the question, but that's what we did.
And I just want to emphasize, so we're doing both. So we do the semantic and the quantitative. You can't just do one of them, so to say. So that would not be the full story. And our colleague, Owen McElroy, he has published a few years ago a very nice paper on how to do it step by step.
That's fine. And you mentioned the tool for the first part.
Harmony, yes.
Is that available for people to use?
Yes, Harmony is for free. It's an open source project. So different people can contribute to it if they're up for it. We have actually now contributors from across the globe, which is really nice. We have an art package as well, so people can definitely use it and should.
This kind of things that we did, like Bettina and I went through the questionnaires, is like 400 pages of PDF. So this takes months, right? So this was how it was done in the past, and let's say Owen did a lot of that in the past, harmonizing a lot of British cohorts instruments. So Harmony can just upload the PDFs or the Excel files or whatever, and do that for you in seconds. That's the practicality of Harmony.
Very, very helpful. And then in your paper, you talk about involvement of lived experience experts. And I'm always fascinated by studies where it's a secondary analysis of existing data, and then you get people with lived experience involved, because I think a lot of the time the lived experience experts are involved in projects that are primary data collection, and then it's obvious how they can be involved. Whereas in secondary analysis projects, it's less obvious. So can you tell us about your experience of what that was like and what their involvement was about?
It was a bit of a riddle to me why they aren't involved, because I came from a sort of more clinical applied sort of research. I was very used to involving sort of lived experience experts in my research. And then when I moved to the research of using secondary data analysis, I noticed that wasn't very commonly done. And I think it's actually quite straightforward to do that. So I also wrote a blog post on how to give people ideas on how they could do that. So how we did it in the first instance, so we worked with the National Children's Bureau in the UK, but then we also conducted workshops in Brazil. And in the first instance, we just explored with the young people the whole concept of social connection, which sounds very abstract, right? So we wanted to just sort of understand from them, what relationships do they have? What relationships are important to them? How do different relationships impact their mental health according to their experience? So once we kind of clarified that, we then showed them the items that we had available in the cohorts, and we let them work with the items to help us sort of develop the research question. But also, you know, they said to us, one item that we hadn't included at the beginning was moving address, and they sort of gave us the idea that we should add that in, because if you as a young person move to another place, then you're losing friends. You have to find new friends. So and that's why we added that one into our analysis. I think it's very rewarding, and I think they always have very good ideas that we don't think about. And then we basically did the same workshops in Brazil. And I think especially with this cross-country sort of study, that's really interesting too, because you have young people speaking from the different contexts, and already there you get a better understanding of what do you do with the data, how do you also interpret the data later on.
Yeah, it was challenged for us as well. Like at the beginning, we need to include people with lived experience, but we didn't fit to include them in the tool development, in the Harmony, let's say. But for the research question at this paper, it fits totally fine, because with them, we derive some of the variables that we look upon in the questionnaires, right? So for example, the moving part that Bettina said, it was brought up in the UK workshops and the Brazil workshops. Because Brazil is the different thing. This is one of the differences that we're discussing about later on. But for example, in Brazil, it's a large country, right? It's a continental country with very difficult mobility. So like in the UK, you can take a train and go to Cornwall or whatever, Leeds. You can just go to take a train, go, right? So in Brazil, it's not that way. You have buses, you have planes, which is expensive, not for everyone. So once you go study in a different city, only going to see your parents 1 or 2 years later. You stay a long way from home. So, and especially for students that goes to schools, when you move, for example, if you're son of a military person, you move a lot, right? Or a bank, your father have a job in the bank, you move a lot in the Brazil. You totally lose your connections. And this was brought up here as well. Another thing was brought up was living with half siblings. It was not an effect that we found in Brazil, but was brought up in the Brazilian workshop, because some of the young people said, my mother gives more attention to the stepson or things like that. So some of them felt cast aside. So this thing was interesting. And we look up and we have these variables. And these differences was brought up also in this part of the study.
So we've talked a lot around the context and the rationale and the process of the research. Let's just get into the research questions and the findings. What were you specifically interested in, and what did you find?
First of all, finding any social connection factors in the cohorts, in both of them, and how these, the ones that are common across both of them, how these relate to mental health outcomes in adolescents in the two countries. And in the first instance, we looked at it separately in each country, but then we also looked at it combined. So is the impact the same in both countries, or are there specific pictures or associations that are very unique to one of the countries, so to say? In the end, with the help of the lived experience experts and the data we had available, we had 12 different social connection factors, very broadly in terms of the findings, and to kind of come back to we need to understand what's similar and different across countries. I would say the one factor that stood out the most is the bullying factor, that played a big role in both countries. And then there were specific factors which were quite unique to either Brazil or sort of UK adolescents. And then, so in Brazil, for instance, we had the household size was sort of a more unique sort of association, which we didn't find in the UK, so to say.
Oh yeah, this is the main things that we want to look at. So there's a step-by-step process in the paper, right? To find the variables and then to analyze if the social connectors variables relates to our outcomes. And the important thing is that we did that in many ways and adjusted for important things, like for sex, for maternal education. We adjusted for prior symptoms, which is quite interesting. So what we found was these social connectedness variables predict new symptoms that your previous symptoms did not predict. So above and beyond that, and you adjust for this kind of thing. So we use also weights to adjust for the representativeness of the samples. And we did that in many angles. Like as Bettina was saying, we analyzed for separated for each country, and we did a meta-analysis as well, and the individual level. This is the more interesting and the main results. That was Bettina was saying is actually what we found in terms of the bullying aspects. Was bullying predicts more internalizing and externalizing symptoms in both countries, but also it have a special effect in the UK.
Yeah.
Being bullied or done bullying predicts externalizing symptoms in both countries, but more in the UK. So we have an interaction effect there. And also we found, for example, in the Brazil, the more people in the house predict more internalizing symptoms. This possibly have socioeconomic interactions there, which we didn't test, but it's possible that we have some different hazards that UK you don't have. And the bullying thing is very interesting in terms of the discussion, because we found some materials that we mentioned in the paper that there's different types of bullying, right? So in the UK, it's more frequent the type of bullying that you exclude someone from the social connection. Bullying relates more with excluding that person from the group, right? In South America, Latin America, you have more bullying about physical aspects, but you call someone fat, but you also called him to play football, right? You don't exclude them. So perhaps these differences might explain why bullying in the UK is more problematic than was in Brazil.
Excellent, thank you. And for the people who are listening, who are researchers or practitioners, what are the implications of your findings?
I think in the first instance, I would say it supports the idea of that this type of research, this cross-country comparison is important. And I think I see this as a first step now with some of these concepts. And you can probably tell from, when Mauricio shares his understanding of how things work in Brazil, or how, society is set up there. And then if we compare it to like UK, even if it's sort of about transport and things like that, it shows you how much difference there is. And this is the first step to identify which broader differences are there. And then we need to kind of zoom in further to better understand it, because then in the long run, this is what we need to really inform sort of interventions and policies and things like that.
I agree with Bettina. I think there is two main messages from this paper, right? First is the method, right? How to harmonize, how to include people with lived experience, to select the variables, how to put data together from different countries, and then do the analysis in multiple ways to take an understanding from the data. And I think for adjusting from prior symptoms is very, really important to understand a bit of causality and try to exclude reverse causality parts of things. So, and the other thing is the main message. So, for example, we found that move to a different city, which is something that people with lived experience told us that was important, and then we picked up, is related with increased internalizing symptoms later on, right? So, child that moves to city is important for both UK and Brazil, and this child should be protected or looked upon. Like they are at risk for increasing their internalizing symptoms. That's an example of main message. People that suffer bullying, people that doing bullying, they are at risk for internalizing symptoms, and the UK should look that more closely because it's strongly linked with these symptoms in the UK. I think at least look for some of these factors and try to identify people at risk for higher levels of symptoms, right? And this, as a whole, children in Brazil have more symptoms than the UK. So the latent variables that we look at the latent means. Brazil have like a half standard deviation worse internalizing symptoms and a standard deviation higher in externalizing symptoms. And children in Brazil are more symptomatic for many reasons, but nonetheless, we are predicting people that will increase their symptoms later on. And these social connected variables are important. Like some, we didn't find any results, like parental death, we didn't find any results. Widowing, we didn't find any results, but some we found, like half siblings. Brazil have twice half siblings living in the household than in the UK. It's 25%, and the UK is 13%. So we have these differences, but nonetheless, these variables are strongly linked with these outcomes anyway.
In addition, for me, what I liked about this and what I took away from your paper was the importance of having not only people with lived experiences as part of the co-design process, but researchers who are embedded in the different contexts as part of the research team. Because often, I think one of my criticisms with any sort of grant that I might review where there's some involvement of people with lived experiences is that, well, if you don't have people as researchers in the research leadership team who are embedded in the context, you're not asking potentially the right questions. Because if you just have people with lived experiences on your advisory panel or your co-production panel or co-design panel, then you've already decided on the questions and you're asking for their opinion. But actually, if you have people who are embedded in the context at the research team level, then they are involved in designing and asking some questions that you might not think of in a UK context, for example. And I've taken that from this because I think I just don't think it can be said enough that it's about having people who understand the context at all levels of the research, on the research team, in the lived experiences, etc., not just in one aspect. So that's what I took from this as well. And what do you have coming up that you'd like to make people aware of?
Yeah, probably quite similar or related to the whole cross-cultural sort of question is we're currently working on developing guidelines on how to guide researchers to, harmonize and pool data sets from studies from different countries, because we found that there are no guidelines yet. So there are guidelines on, how to generally sort of do the harmonization, but there's not much guidance yet on how to account for cultural differences on all levels, right? So not just in the harmonization stage, but also when you analyze it and also when you interpret and make sense of the findings. So that's currently what we're working on. If there are any experts out there that would like to sort of share their knowledge or their opinions on how this could be or should be done, then we would be very happy to hear from them. And in terms of harmony, we are currently exploring it with different countries. So we're also trying to test harmony out with a research team in South Africa, because they're different languages, and some languages have the word depression, for instance, and some languages don't. So how do we overcome that? Generally, we're just trying to expand harmony as a tool because we think it's very useful for researchers. So if anybody's keen on contributing to that, then we welcome this as well.
That would be really interesting to read, because I think, again, like the data harmonization stuff, like you say, there aren't guidelines out there. So for researchers, it would be very helpful. Can I tell you what I would like to see? Not necessarily from you, but from anyone, is I think from a place of a person, a researcher who uses does secondary data analysis, existing data sets as a day job, like I use this all the time, is I would like to see a paper that comprehensively talks about the drawbacks and limitations of secondary data, because not the answer to everything. And I think that as a person, and maybe you and everybody else as well, as people who are involved in it so much, we might not always see why secondary data isn't the answer to everything. And I sometimes, like when I'm speaking to students or potential PhD students or potential collaborators, I'm like, yeah, secondary data is great and I use it all day, every day, but it doesn't do everything, and there are lots of problems with it. But actually, I can never put into like a coherent argument or coherent structure of what's wrong with secondary data. So it'd be nice if somebody would do a paper on these are the problems and limitations with secondary data. It does have problems, and you can't do everything with it, but you can do a lot, and there's lots of positives as well. And finally, what's your take-home message for our listeners?
From this paper, I think the take-home messages are, it's not a tutorial paper, it's not a primer paper nor anything, but we try to give some possibilities of how to answer this type of questions in terms of methodology. And we try to pinpoint which people we have some social connectedness factors perhaps are at risk for a few years later developing more symptoms, right? So perhaps looking at, like, policymakers looking at this kind of things, particularly in some places, might be important to prevent higher symptoms, is assuming causality, right? But like bullying, moving from town to town, household compositions, these kind of things, like housing is an important thing, right? So to put 5 people together in one room place might be problematic for the children.
Bettina, Mauricio, thank you so much for taking the time to join us.
Thank you.
Thank you.
As always, please visit the ACAM website, www.acam.org, and on X @ACAM, where you can find out more about Dr. Jackson. ACAM is spelled ACAMH. And don't forget to follow us on your preferred streaming platform. Let us know if you enjoy the podcast with a rating or review, and do share with your friends and colleagues.